We looked at CDC recommendations for HIV pre-exposure prophylaxis. Now, given an HIV-exposed patient, recommend appropriate post-exposure prophylaxis regimen or PEP. When it comes to post-exposure prophylaxis, there are two different guidelines. There is one that's occupational post-exposure prophylaxis or OPEP, which primarily refers to the healthcare setting. For example, if you get a needle stick. There is also non-occupational post-exposure prophylaxis, so things like sexual assault or unprotected sex or exposure to injection drug use. We will focus on non-occupational post-exposure prophylaxis. The recommendations are basically identical. So the post-exposure prophylaxis should be started as soon as possible. However, it should not be started beyond 72 hours. So it's only effective as long as it's started within 72 hours. And because this is post-exposure, so possibly the virus could be inside the patient's body. Therefore, as opposed to pre-exposure prophylaxis, which was just the backbone, the post-exposure prophylaxis includes the full treatment. So you need the backbone, which is typically tenofovir, desoproxil, emtricitabine, plus a third agent, which is either raltegravir or dolutegravir. And alternatively, this third agent could be darunavir boosted with ritonavir. So these are the agents that have been studied, so that's why we shouldn't use anything else. For example, bictegravir and elvitegravir have not been studied for post-exposure prophylaxis. So our options are raltegravir and dolutegravir and darunavir. Another thing to note is that raltegravir twice a day dosing is studied for post-exposure prophylaxis. So the more recent formulation of raltegravir that's dosed once daily should not be used for PEP. It's only for treatment of HIV. And lastly, the new formulation of tenofovir TAF, which recently got indication for PrEP. It's not indicated for post-exposure prophylaxis, so it has not been studied for PEP as of yet. So therefore, we have to use Truvada as the backbone plus a third agent. And of course, we don't use a bacavir-based backbone because there is no time to check for HLA-B5701. We gotta start treatment within 72 hours, and the treatment is for 28 days. So this is fixed. So we just treat for 28 days. And hopefully after 4 weeks the patient will not develop HIV infection. As always, it's important to provide education to the patient regarding adverse effects as well as checking for potential drug-drug interactions. So basically, when someone gets exposed to the virus, of course, if the risk is negligible, the PEP is not needed. But if there is reasonable evidence that the patient has been exposed to the HIV, if it's been more than 72 hours since exposure, then PEP is not recommended. We'll just wait to check for HIV, and if the patient develops HIV, you just treat the HIV because post-exposure prophylaxis will not be effective. But if it's been less than 72 hours, now post-exposure prophylaxis will be very effective, so there's potential to prevent HIV infection. Now, if we do know the source, so for example, if somebody had unprotected sex with someone, we can potentially test the source and see if they're HIV positive or HIV negative. So if someone happens to be HIV positive, then definitely we start post-exposure prophylaxis. And then if we don't know the source, for example, in cases of sexual assault or rape, we just have to go case-by-case basis. In most cases, we would actually go ahead and do post-exposure prophylaxis. Now, when it comes to monitoring for post-exposure prophylaxis, so if we do know the source of the infection, it's helpful to check for HIV to see if the source actually had HIV, because if they didn't, then post-exposure prophylaxis will be unlikely. And then some of the other things that can be transmitted in the same way, such as Hep B, Hep C, some of the sexually transmitted infections like chlamydia, gonorrhea, and syphilis. These should be also tested in the source. And then in the patient who was exposed, also they need to be tested for HIV, as well as for Hep B, Hep C, and sexually transmitted infections. And then because we are to start post-exposure prophylaxis, we also need the serum creatinine and liver chemistries, because we're going to use Truvada and depending on whether you use raltegravir, dolutegravir, or darunavir, these will be used for monitoring. And then in 4 to 6 weeks, we check for HIV again. That will be at the end of treatment. So treatment is basically for 4 weeks or 28 days. So we check one more time, and then one last time we check HIV 3 months after exposure, just to make sure that post-exposure prophylaxis actually worked. So if this one comes out to be negative, we know that post-exposure prophylaxis worked and the patient did not get HIV. On the other hand, if this tests positive, then unfortunately the patient is diagnosed with HIV, and then they need to go on lifetime treatment. Now, one scenario where you would need to check HIV 6 months after exposure, if someone also get test positive for Hep C, because it's been shown that people who have Hep C while they were exposed to HIV, the seroconversion, meaning development of antibodies, will be delayed. So you would be detecting that at 6 months. So that's the only time you would get it at 6 months. And of course, in females of reproductive age, we also check for pregnancy at baseline and then at the end of treatment. And that's really just to make sure that we do a better job of follow-up, because if the patient does develop HIV, the patient can transmit the virus to the fetus. Now, depending on the situation, on how the patient got exposed to the virus, for example, if it was unprotected sex, and if the patient has that risky behavior frequently, it might be a good intervention to transition from PEP to PrEP. So once we complete the 28 days of post-exposure prophylaxis, we can have a conversation with the patient if they think that they will continue the risky behavior after PEP. If the PEP was successful and the patient did not develop HIV infection, then upon a negative HIV test, we can actually give patient PrEP. So, depending on whether you gave patient PEP formulation, either raltegravir with Truvada, or dolutegravir with Truvada, or darunavir with Truvada, this will be for 28 days. And then after 28 days, you just give them Truvada as PrEP, and they will be on Truvada as long as they continue the risky behavior. Now, the Senate Bill 159, SB 159, that will be effective July 2020, expanded services of pharmacists to HIV PrEP as well as HIV PEP. So pharmacists can furnish HIV post-exposure prophylaxis starting July of 2020, as long as the pharmacy gets a training in it. So typically, I imagine a 1 hour CE will be required, or maybe if more CEs. But most importantly, the pharmacists can furnish a complete course. Now, they don't specify what complete course is, but they do say that they will be referring to the CDC non-occupational post-exposure prophylaxis guideline, which would define the complete course as 28 days. So what they really mean here is a 28-day course of post-exposure prophylaxis. And then they follow the same requirements as the CDC guidelines. So it has to be within 72 hours of exposure. And just like PrEP, the pharmacist is required to provide full counseling to the patient, including transition to PrEP. And the patient may not actually waive this consultation. So it's actually required.